Yeah. So welcome to Decoding CTO case 34. I'm Dr. Sharath, interventional cardiologist at Recover Hospitals, Hyderabad. Today I'm presenting a case of IVUS guided retrograde wiring in an intramural hematoma created by ANTEGRADE wiring effort. This patient is a 60-year-old male, came with unstable angina, had fair LV function, and CAG showed mid-RCA total occlusion, kind of spontaneous dissection, bar a total occlusion with recognized RCA, and he has comorbids of hypertension and diabetes. This is the angiogram. You can see mid-RCA is deceased, but it appeared there is a good microchannel going along the CTO segment, but you can as well appreciate a lot of loops within the microchannel. Often it is very difficult to track these microchannels with our microchannel tracking wires. And yeah, so left system is fine. There is not much of issue on left system, and you can as well see the branches, multiple branches coming from the distal RCA. This is left system. You can see there are good septal collaterals filling PTA from LID. Coming to JCTO score, proximal cap is clear, and there is no calcification, there is no bands. Only length is bit longer, so more than 20 millimeters, and so overall JCTO score is 1. So at the outset it appeared a very simple lesion to cross and complete. Yeah, wiring strategy, obviously first is ANTEGRADE. So ANTEGRADE wire escalation. So if microchannel wire doesn't cross, then we can go ahead with directed wire tracking. If that doesn't work, probably we can go to retrograde, or we can do ADR and close it. So yeah, the first operator started this case. You can see here with a single guide, no dual injection, and this is how they started wiring. See, and you can see the movement of the wire. So this kind of buckling of wire happens when wire is subintimal, and there is a true lumen from here in the vessel. So, but still the wire is buckling. That says it is subintimal. And such a buckle creates a wide subintimal space, so kind of intramural hematoma. And you can as well see what happened here. It is almost getting knuckled within the subintimal space. So this kind of handling of wire is definitely not conducive for ANTEGRADE success. That's what exactly happened here. So there was a huge subintimal hematoma got created, and since this minimized visibility of the distal vessel, they took even retrograde injection with a 5 French catheter. You can see this is a 6 French guide, and this is a 5 French diagnostic with which they injected retrogradely just to locate where the wire is, or wide to true lumen relation. So at this stage I was called for a help in this case, so I immediately changed guide to AL 7 French, you can see, and we took a dual injection then. So when I gave a dual injection, so now the vessel which was clearly visible before here is not clear now, but whatever contrast is going here. So now the question is it a true lumen or false lumen? So it is most likely a false lumen created by filter XTR wire. So from this point, your possibility of directed tracking with your Gaia wires becomes much more difficult, since we can't decipher what exactly it is, whether it is true lumen or false lumen. So at this stage, what are the options I have? Yeah, I mean the ANTEGRADE options, whatever you do, since there was a huge subintimal hematoma, all your whites goes only into subintimal hematoma. And the second option, if I have to complete it antegradely, is choose a re-entry zone and advance wire and do a re-entry. So, and this would be beyond, you know, this beyond this branch. So there is every chance, you know, I lose this major branch, you know, which is coming from RCA. So I felt that was not a great option. And we can do a re-entry, that is tip detection ADR with intravascular ultrasound somewhere here, so that you don't lose this branch. But still you have you will have a significant subintimal stenting, you know, from above. So the next option, you know, which is with which, you know, you can overcome other two problems. You know, you can preserve this branch. You can also minimize your subintimal stenting, is going retrograde. Since this CTO is not longer, so you can just go retrograde, as there was a good intervention collateral, and cross from true to true if possible, or you can even do a reverse cut here and complete procedure. So this was the best option among the three available options. So we went ahead, you know, and did a septal angiography and crossed, you know, septal, and now you can see how the wire is going. All this area is actually occluded, and all this area, you know, the wire is going quite easily antegradely, but through the true lumen. Sorry, in retrogradely through the true lumen, but antegrade it is already, the tracks are into subintimal, so it's difficult to reach, you know, true lumen antegradely. Yeah. So once the wire is at the distal cap, so we upgraded wire to Gaia 2. So this is Gaia 2 with which we just navigated across the total occlusion. And you can see this is antegrade microcatheter which is sitting here, so waiting to do a reverse cut. So then we did a reverse cut here. It's almost a conventional reverse cut with a 3 millimeter balloon through the guide extension catheter. But despite repeated efforts, I was not able to bring wire back into, you know, antegrade guide extension. So that's when I thought, okay, we did an IVUS just to understand the relation of antegrade wire to retrograde wire, and you can appreciate here. So this is the antegrade, you know, subintimal space which was created, and this is antegrade wire, and you can see this is a retrograde wire. So retrograde wire is actually in the true lumen, antegrade wire and IVUS is in the false lumen. So you can see here, so my antegrade system is in the false lumen here. In fact, even guideliner also is in the false lumen before. And this is IVUS catheter, and this is a retrograde wire which is sitting in the true lumen. So the options now, yeah, it just go ahead with a conventional reverse cut with a you know, concavous pro wire retrograde, and perforate through this you know, flap, and get into the antegrade lumen. So that was one option. Or otherwise we can also continue and retrograde true lumen tracking, keeping antegrade IVUS as looking in antegrade IVUS. So that's what we did. So yeah, watching the wire location and with antegrade IVUS step by step, you know, we advanced retrograde wire proximally, and you can see here now. So what happened, so you can see this is the antegrade wire, this is a retrograde wire in the true lumen which is compressed. Now still it is in the true lumen, and now it came to, you know, the same lumen. Both the wires are in the same lumen. You can see finally they are in the same lumen proximally. So, and once we reached antegrade true lumen, so we took a guide extension catheter and then advanced retrograde microcatheter into the guide extension and trapped and externalized. So post externalization we pre-dilated. So we have to keep in mind, there is a huge intramural hematoma here, and we shouldn't inject in such patients with contrast. So use a guide extension, advanced guide extension, so that you can possibly prevent further expansion of intramural hematoma, as it separates IMH from aortic pressure to some extent. So we did IVUS post pre-dilatation. So you can see how the vessel looked like. So you can see here, this is IVUS, this is all subintimal hematoma sitting here. So at some point you can see here the true lumen is separated all around, circumferential kind of dissection. So you can see this is all intramural hematoma, and true lumen is completely compressed, and you can only see IVUS in the true lumen, and all the branches are coming from the true lumen, which you can appreciate here. So no branches from false lumen. So that's how there is a very significant intramural hematoma. You can see this is a CTO segment, and yeah. So at this stage, we decided, if you stunt this like with a stunt, then there is every possibility this IMH can be squeezed down and can close the branches and also close the distal vessel. So it is prudent to make some fenestrations so that it will drain back into true lumen, and IMH won't propagate on either side of the stunt edges. So we decided to, okay, so this is same IVUS after pre-dilatation. You can see this is all IMH, and then we went ahead with Wolverine 3, because the vessel is around 3.8. we did with a 3 Wolverine balloon. So we did a and after that again we did IVUS. You can see here. So despite Wolverine, I couldn't see any fenestration within the flap, and you can as well see the clear difference of speckling between the two lumens. So since there was no fenestration, so we decided to go ahead. You can see here. So we decided to go ahead with the NC dilatation, and that's a maximum NC which is allowed here. Here the size is 3.8, even taking IMH into consideration. So that's, I don't want to take a 3.5 cutting balloon, that might complicate it further. Already injured vessel, chance of perforation will be a bit higher. So we took a 3.5 NC balloon, short NC balloon, and dilated to almost 20 atmospheres here, exactly at the point where the IMH, where the intimal flap is separated from the wall all around. So that's where we did this, and yeah, post Wolverine and post 3.5 POBA, there we realized we could create a good fenestration. You can see here. Yes, yeah, this is where there is a huge fenestration created, and you can as well see the speckling in both lumens is almost equivalent now. So at this stage yeah, we decided to go ahead with stunting. You can see here, yeah, this is where there is a fenestration. There is a huge fenestration here. In fact, even wire is appearing as if in the false lumen. So this is a fenestration. There is a long fenestration created here, and now when you stunt this vessel, position stunt like this, and then what we have to do is, before we deploy stunt, keep another balloon here and occlude the vessel. So now this intramural hematoma or intramural collection is separated from aorta pressures. So when you try and deploy this stunt, all this will flow back into the true lumen. So that is what we did. So took a stunt, position stunt there, and you can see we dilated the balloon proximally, and then we deployed stunt distally. After 15 to 20 seconds pass, we deployed stunt distally. So, and you can see this is how first dilate this balloon and then deploy stunt. And now we can see this is the final result. We also stunted with another 4 mm stunt proximally, and this is the final result. So all the branches are preserved, and absolutely there is no intramural IMH extension into the downstream vessel, which we can also see in IVUS. So this is a final IVUS. You can see this is a distal vessel which is around 4.5 mm square. You can see this is the distal stuntage. There is no IMH propagation, and that is what exactly we wanted. And you can see this is the stunt, which is 8.9 mm square, 10 mm square, 10.5, and ostial RCA is almost 12 mm squared. So good MSAs. To conclude this case, so approach to CTO should be meticulous and uniform, without any lenience from the first step onwards. And creation of multiple tracks or a wide space in antegrade wiring will reduce chances of antegrade success. And retrograde wiring would be an option to minimize subintimal stunting and maximize branch preservation in patients where IMH, huge IMH is created by antegrade wiring. Creating fenestration and proximal balloon occlusion would prevent propagation of IMH and also preserves branches flow better. Thank you. To watch more such videos, you can subscribe to our YouTube channel, Interventional Strategies, or we can even visit our website, drsharathreddy.com.